Management of Raynaud's phenomenon has advanced with new insights and therapies. Treatment focuses on preventing attacks, improving blood flow, and managing complications. Below is an updated approach based on current evidence. 1. General measures. Lifestyle modifications. Avoid triggers like cold exposure, emotional stress, and smoking. Wear warm gloves, socks, and layers in cold weather. Use hand warmers or heated gloves if necessary. Education. Teach patients about self-monitoring and early identification of ulcerations or complications. 2. Pharmacological treatment. First-line therapy. Calcium channel blockers, CCBs. Nifedipine, 30 to 60 milligram per day, or amlodipine, 5 to 10 milligram per day, remains the cornerstone of therapy. Improves vasodilation and reduces the frequency and severity of attacks. Second-line therapies. Phosphodiesterase 5 inhibitors, PDE5 inhibitors. Sildenafil or tadalafil is effective in resistant cases or digital ulcers. Improves microcirculation and endothelial function. Prostaglandin analogs. Intravenous iloprost for severe digital ischemia or ulcers. Promotes vasodilation and healing. Adjunctive therapy. Topical nitrates. Nitroglycerin ointment can be applied locally to improve digital blood flow. Alpha-adrenergic blockers. Prazosin is useful in refractory cases to relax vascular smooth muscles. SSRIs, e.g. fluoxetine. Beneficial for vasospasm in select patients, especially with stress-related triggers. 3. Advanced therapies. Botulinum toxin injections. Reduces digital ischemia by inhibiting sympathetic vasoconstriction. Effective for refractory Raynaud's or severe ulcers. Endothelin receptor antagonists, e.g. bosentan, useful in systemic sclerosis-related Raynaud's to prevent digital ulcers. 4. Surgical and interventional options. Digital sympathectomy, consider for severe resistant cases with digital ulcers. Improves blood flow by interrupting sympathetic nerves. Arterial interventions. Angioplasty or other vascular procedures may be needed in rare cases with arterial stenosis. 5. Disease-specific management. For secondary Raynaud's, e.g. associated with systemic sclerosis or lupus, aggressive management of the underlying condition is essential. Immunosuppressants or disease-specific therapies may help. 6. Future and experimental therapies. Stem cell therapy, promising results in early trials for severe refractory cases. Vasoactive biologics, ongoing research into targeted therapies for microvascular dysfunction. HAD, monitoring and follow-up. Regular assessment for digital ulcerations, complications like infection or gangrene, efficacy and tolerability of treatment, patient-centered care, personalized treatment plans based on the severity, frequency of attacks, and underlying conditions. Would you like details on a specific therapy or an algorithm for management? The management of Raynaud's disease, primary Raynaud's, and Raynaud's syndrome. Secondary Raynaud's differs due to the underlying causes, severity, and risk of complications. Below is a comparison of the lines of management. 1. General measures, common to both. Avoid triggers, such as cold exposure and stress. Lifestyle modifications, like smoking cessation and wearing warm clothing. 2. Management of Raynaud's disease, primary. This is a benign, idiopathic condition with no underlying systemic disease. Goals: prevent symptoms and improve quality of life. First-line treatment: calcium channel blockers, CCBs, nifedipine or amlodipine to reduce vasospasm. Adjunctive therapies: topical nitrates applied locally to increase blood flow during attacks. Behavioral therapy: biofeedback or relaxation techniques to reduce stress-related episodes. Avoid aggressive treatments. Since complications like ulcers are rare, advanced or surgical interventions are usually not required. 3. Management of Raynaud's syndrome, secondary. This is associated with systemic diseases like systemic sclerosis, lupus, or vasculitis, and is often more severe. Goals: prevent complications, e.g. ulcers, gangrene, and treat the underlying condition. First-line treatment: calcium channel blockers, CCBs. Higher doses may be needed compared to primary Raynaud's. Phosphodiesterase 5 inhibitors, PDE5 inhibitors, sildenafil or tadalafil for severe vasospasm or digital ulcers. Second-line and advanced therapies: prostaglandin analogs, e.g. iloprost, Intravenous infusion for severe ischemia or ulcers. Endothelin receptor antagonists, e.g., bosentan, prevents recurrent digital ulcers in systemic sclerosis. Botulinum toxin, local injections for refractory cases or ischemic digits. Treat the underlying disease, immunosuppressants, if associated with autoimmune diseases such as systemic sclerosis or lupus. Disease-modifying agents for underlying connective tissue disorders. Surgical or interventional options, digital sympathectomy for severe resistant cases with non-healing ulcers. Vascular surgery, considered in rare cases of severe arterial obstruction. Monitoring and complication prevention.